So this morning I have the privilege of speaking to you about designing and implementing an effective performance improvement program, and that may be somewhat of my own arrogance in that I think that we have a reasonably mature PI program. My only disclosure on this talk is that I do verification and review visits for the American College of Surgeons, so I'm often the person who's looking through everybody else's charts. And I know how stressful it can be because somebody came and looked through all of our charts recently. So here we go. One of the reasons that we're here is that we want to do the best things for our patients and have them get better care, better outcomes, and provide more efficient care. And that is really the goal of performance improvement work. The reason that performance improvement work has become so important are these two relatively scathing reports from the Institute of Medicine, which basically said that we weren't providing the level of care that we needed to provide to our patients to keep them safe and healthy. When you look at outcomes research and performance improvement, Avidius Donabedian is basically the father of this entire framework, and he's taught us to look at healthcare quality through three windows: structure, process, and outcome. And up until about the year 2014, most of our processes have been structure and process. I'm going to start to talk a little bit about outcomes, as I think Dr. Nathans did earlier yesterday. When you look at the modern era of healthcare, we're wasting about 30% of our healthcare dollars doing duplicate testing, making mistakes, things that create no benefit for our patients: overtreatment, failure to coordinate care, etc. And what all this is doing is driving up costs. And as you can see, imaging and testing are the two things that are really driving the cost metrics. So there's a huge focus now on creating value for the patients. I'm looking for my... Can I have a pointer? Oh, there you go. Thank you. So outcomes are really defined by the patient. They want to get in, get their operation or whatever it is that they need to have done in the hospital and get out in one piece without any complications. And it should be measured for the patient's entire episode of care as compared to cost. And when you look at value, value is healthcare outcomes over the cost of delivering care. I submit to you that as we improve value for our patients, minimize variability, and structure things to get our patients through without the complications that we've had, we are actually providing, one, better health care, and two, cheaper health care. So what is performance improvement? It is the continuous evaluation process of outcomes of care, and it does not automatically assume that the care that you are providing is poor. It rests on recognition, assessment, and correction through data collection, analysis, modification, and instruction. I love this quote. Change happens when the pain of staying the same is greater than the pain of change. And I submit to you, in the year 2014, we are all experiencing a great deal of pain at staying the same as we have our healthcare dollars cut. So when you're doing performance improvement, there are three questions that you can ask, and they're the Nolan questions. What are you trying to accomplish? How will you know when the change is an improvement? And what ideas do you have that might lead to an improvement? And I submit to you that you do not need to reinvent the wheel to do this. There are a bunch of other trauma centers in the country that are publishing their data and how they are implementing performance improvement processes at their institution. And a lot of things can be learned from taking stuff from our colleagues, hopefully with permission. So when you're trying to improve, what you need to do is understand your current process, which is often difficult. I don't know if you work in an institution like mine, but it is frequently virtually impossible to figure out how to get from point A to point B in a care process. Apply the tools of your current process and identify opportunities, and then develop possible changes and tests, so best practices, evidence-based guidelines, and copy something that works elsewhere, because we do not all live in a vacuum. So this is the PIPS roadmap out of the new Orange Book. How many people have seen the Orange Book? It's out. Y'all haven't seen the Orange Book? There's a lot of controversy about the Orange Book. So I think the VRC has their work cut out for them. But in any event, so you have to have a performance improvement authority and team members that are capable of identifying events from various sources, including monitoring, reporting, and tools. Whether that's a download from your trauma registry or a download from your electronic medical record or somebody running around with a piece of paper keeping track of your patients. You then have to investigate, validate, and analyze the event to determine whether or not it is within the standard of care or if there is something that you can do to improve the process. And by doing this, you look at case reviews, and there are various levels of reviews that we'll discuss shortly. Then you determine a process of outcome determination and implement a corrective action. And I'm sure you all have seen this, the Plan, Do, Study, Act circle. And what it is basically just repeated evaluations of the Plan, Do, Study, Act. So once you've acted, then you have to restudy and replan. Some of the ways you can identify root causes are to determine whether or not it's a process issue or a systems issue, and I suspect most things are a combination of the two. And then there are strategies to break down system issues. So the diagram on the left is our flow map of our surgical site infection problem at Yale New Haven Hospital. And as you can see, there are multiple steps, and there is a test on this, so I hope you all can read it. Or you can do a fish diagram, which is the diagram on the right, which I shamefully stole from Hopkins. Or you can just ask why 5 times and all pretend that you're 2-year-olds. It's really kind of annoying when they do that, isn't it? But what really improves outcomes and what is so important for performance improvement is not only to do the process design, the CQI, the root cause analysis, the evidence-based practices, et cetera, but you have to integrate that with behavioral accountability, because that is really where you get your optimized outcomes. You have to stop the behaviors that are continuing to allow the processes that are problematic to perpetuate. And I can't believe I got that out without stumbling. So let's talk a little bit about quality and care, and there's the little orange book with the broken man right there on the bottom. Let's talk about the big picture. So the orange book is starting to move the process from a focus on just programmatic structure and process outcome to a focus on outcomes. And again, we can talk about levels of review. But primary review is usually done either by the trauma program manager designee or perhaps by the trauma medical director. And if there is a problem identified, then secondary review involves medical record review and a local trauma performance improvement process. If the problem seems to be more systematic, then you can go on to your tertiary or multidisciplinary review. And then some of us have the beauty of quaternary review, which is the hospital-wide PI or external review process. So what are your potential interventions? Well, we've talked a little bit about practice management guidelines and protocols. We've talked a little bit about targeted education. And I would stress that it's not just a one-time round of education. These are things that if you allow people to return to the status quo, they will return to the status quo. So it's repetitive education. Resource enhancement, sometimes you need to counsel people. Sometimes you need to do some focused professional practice evaluation. And occasionally you need to modify people's privileges, and we all know what that means. That's the polite way for saying, there's the door, have a nice day. The other thing that's really important about process improvement is loop closure. You have to demonstrate performance improvement that has a corrective action that has reached the desired result. So you really don't want to have this gap between your estimated pose, or what you think you're doing, and your real pose. So the questions you should ask yourself as you're looking at your loop closure is, has the corrective action made a difference? Was the desired effect realized? Did the rate of the occurrence change in the desired direction? Oftentimes it does, and then it tends to drift back towards the status quo. Is the correction complete at the level needed? And do you need to continue to monitor? And I submit to you that you really do, because again, people will drift back towards the status quo. So loop closure failures are not impacting provider performance, not impacting system performance, or not impacting outcomes. And sometimes you just have to reboot the mission and start over. So let's talk a little bit about how to do the heavy lifting of process improvement, and I'm going to share some things that we've done at Yale New Haven Hospital that I think have worked well, and some things that may not have. In 2009, we developed our pelvic fracture management guideline, which was adapted from the Western trauma algorithm. And in that, paragraph 2 said angiography should only be undertaken in a hemodynamically stable or easily stabilized patient with blush on CT after discussion with the key players, so the trauma surgeons, the orthopods, and the interventional radiology attendings. And we thought that was working fine until we got patient JF, who was transferred 2 years later. A hemodynamically unstable patient after a motorcycle crash had a very significant pelvic fracture and went to angiography after receiving 4 units of cells. There was no clear arterial blush, but the interventional radiologist said, well, there may be some venous pooling, and prophylactically embolized the left internal iliac artery. The patient then went on to surgical stabilization and necrosed his buttock, which is not a good outcome. So we looked at our pelvic fracture algorithm and we added the following statement, which basically said prophylactic embolization without a clear indication is not indicated. We thought that would solve the problem. Then we got patient CD about 4 weeks after we put this protocol into place. Hemodynamically unstable male, crushed, had an isolated pelvic fracture. He had an angiogram that showed contrast extravasation, which was appropriately embolized from the right internal iliac artery, but then spasm in the left internal iliac artery. So we took out both of his internal iliac arteries, and lo and behold, he had buttock necrosis requiring tissue transfer. So we decided we hadn't really fixed the problem. And we modified our protocol again. It took us a little bit longer this time, 2011, 2012. To any attending orthopedic input is required prior to any non-selective embolization, so main branch embolization, or bilateral pelvic embolizations to cut down on this problem. And I will say that occasionally the interventional radiologist is really annoyed trying to get a hold of the orthopedic attending, but we have not had a single case of buttock necrosis despite some very significant pelvic fractures in the last 3 years, or 2 years. So an effective loop closure with PDSA over and over again. The other thing that I wanted to talk about, and Avery Nathans touched on this, is TQIP. So TQIP and the American College document specific structures and process, including multidisciplinary program process improvement, but they want you to externally benchmark your performance, and NTDB is no longer good enough. So how do we measure outcomes, and how do we assess our progress? If you can't measure it, you can't manage it. There are a bunch of places that actually look at our performance, including the Joint Commission, the IOM, et cetera, and things like consumer reports. Now, I don't know if you had the opportunity to look at a recent consumer reports, and by recent I mean sometime in the last 5 years. But the major academic medical centers on the East Coast were evaluated by consumer reports, and they scored approximately equivalent to a UGO. Y'all remember the UGO? Yeah, so those are what we would call lower quality evaluations. Things like NHSN, NSQIP, TQIP, STS, UNOS, et cetera, are probably higher quality evaluations of performance. And TQIP provides a risk-adjusted benchmark for outcomes. So how do we at Yale New Haven Hospital incorporate process measures into our PI? Well, in 2010, we got our TQIP report, and this was basically patients who died, risk-adjusted mortality. And that arrow, boys and girls, which is all the way over on the right, which is really not where you want to be, trust me, I know, was us. Yay. So we said to ourselves, are we really that bad? Our mortality rates are lower than average. We didn't think so, so we actually did an evaluation of the type of data that we were submitting to TQIP, and we discovered that we were missing age on some of our patients. We were missing admission GCS, which is an extraordinarily important risk stratifier, and we were not coding any comorbidities. And when I realized that, I kind of wanted to crawl under the desk and, cry, but we got together with our registrars, and thank God they are wonderful people. They've done a great job of correcting the problem. And this is where we are today, smack dab in the middle of where we want to be. A little bit more dirty laundry in a minute, but what we realized from TQIP initially was that our risk adjustment was not accurate, and we were failing to capture significant comorbidities. And particularly, we were failing to capture significant comorbidities in pelvic fractures requiring transfusion because we weren't quantitating how much transfusion they required. So, newer avenues for exploration. This is, again, our TQIP report, and while we're dancing pretty close to the midline, we're almost in an area where I don't want to be for shock. And when we looked at our data, and by the way, we do tend to embolize more than one patient a year, so clearly we're not capturing that data. We had a time to angiography in hours of 22 for our one patient that was captured. So now we're capturing our angiography better. And we're debating whether or not a patient who requires angiography 22 hours after trauma is really in shock. So we had a verification visit, and Glenn Tinkoff, how many people know Dr. Tinkoff? Has he been to your shop? Glenn is somewhat very attentive to detail, shall we say. Love him to death. He's a great guy. He's a wonderful reviewer, but boy, does he go through everything. And Glenn said, along the lines of our TQIP report, so perhaps the verification process actually works. I happen to think that it does. There appear to be provider-based inconsistencies in the use of hepatic and splenic angiography for trauma. Recommend protocol development. So this is our protocol. Again, I want you to read it really quickly. There will be an exam. I think what the take-home message in all of this is that critical evaluation of how you are providing your care allows you to provide better care for your patients. If you go back and you fix the issues that you think are not where you want to be or opportunities for improvement. And I think that while process measures are important to improve the efficiency of care, the evaluation of outcomes using risk-adjusted data is much more important and allows you to drill down on variations in care because limiting variations clearly improves quality. So I think that's all I have, and thank you again for the opportunity to come to a nice, warm, sunny place and meet so many of you. It's been a wonderful trip. Thank you.